We're going to talk today about healthcare. I'm going to talk about healthcare. You're welcome to ask some questions. I expect that we'll have some time at the end for discussion. I was admonished not to provide answers. Yeah. And I thought, I don't have the answers. There's a couple of little places where I could say we could make things better if we did this. But mostly I want to talk about how things are and some of the problems that exist in our system. In general, we're going to talk about this, how healthcare gets paid for, but it's a broader talk than just that. So healthcare, in case you didn't know this, is big business. In fact, it's the biggest industry in the United States, the largest employer, and this is true not just on a national level, but on a local level in many places too. Many, especially rural areas or small urban areas, the healthcare industry is the largest employer. And this is important to make note of, and I'll come back to this a little bit later. Last year, we spent $5.3 trillion on healthcare. For those of you who like to or want to visualize something like that, that's a 5 and a 3 and 11 zeros. Now, fortunately, our economy is bigger than that. It's about $28 trillion is the size of our economy. So this was about 18% of everything that we produced. More than 1/6 of everything that we produced last year went to healthcare. On a per person basis, that's about 15,600. That's a really big percentage. It's a really big number. We look at the number as a share of GDP because it provides a convenient way to make comparisons over time and across countries. How big relative to the size of everything we do is healthcare? So here's a chart that shows that, going back to 1980, and the US is the blue line on the top, and back in 1980, we were pretty much with the rest of the group. These other countries, you can see some abbreviations on the right. I don't know if the font is big enough for you to actually read them, but there are other well-developed countries, and we consider them peer countries for the United States. So we were in the peer group back in 1980, and everybody has seen growth in the size of the healthcare industry and their economy, but the United States has, as we always like to think of ourselves, been special and grown much more than other countries have. So we spend much more per person, we spend much more in our country than any other country in the world. Spending, a couple interesting facts. Spending varies by age, probably could have figured that out. Those 65 plus are about 18% of the population in the US, and that group consumes 36% of all healthcare spending. A statistic I heard a while back was that people consume in their last year of life about half of all of their total lifetime healthcare consumption in that one last year. And if you think about stuff that doctors sometimes do in the last year, okay. And the older a person is, the bigger that number is. Those age 0 to 18 are about a quarter of the population and consume less than 10% of all healthcare spending. And there's graduation, more and more. Spending, I was surprised to learn, also varies by ethnicity. Whites per capita consume about twice as much as do Hispanics or Asians. And blacks consume about 2/3 as much as whites do. So considerable variation by ethnicity. These are averages, so yeah, some people are going to consume more, some people are going to consume less, but that was striking enough for me to make note of it. And there's actually a lot of statistical differences between different ethnic groups, or racial groups, I should say. That's not ethnicity, racial groups. You can look for those if you want. Why has spending risen so much? A lot of reasons. Lots of reasons. And the first category that I have is some decent reasons. I didn't want to say good, because we'd rather not have it rising, but there are some decent reasons. One is rising incomes, and healthcare is considered what we call a normal good. It's normal for when people have more money for them to buy more of some stuff. We buy more restaurant meals, eat out more often. We go more traveling. We buy more new clothes. We do a lot of things when we have more money. Healthcare is one of those things we buy more of when we have more money. We also have an aging population. I just told you, older people consume more healthcare than younger people, so that's going to increase our spending. And we have new technologies. The new technologies tend to be more expensive than older technologies. There's also a bunch of, I'm going to call them less good reasons. Things like we have unhealthy lifestyles. Nobody in here, I'm sure, has an unhealthy lifestyle. But some people do, and we know out in the economy, there's out in the world, there's a lot of them. We have a shortage of physicians, especially general practitioners. We actually have a lot of specialists. Not, I wouldn't say a surplus, but relative to the number of GPs, we don't have enough GPs. Service industries in general experience low productivity growth. It's hard to see twice as many patients in a day. It's easier for a factory to develop new technologies and produce twice as many goods. So we get higher productivity in manufacturing, not so much in services. You've probably been reading down over the past 40 years, the CPI for healthcare services has increased nearly 3 times as much as the CPI for ordinary products. We have an incredibly complex payment system and high administrative costs. It's estimated that the administrative costs for dealing with our insurance third-party payment system cost us about $500 billion a year. Did I put that? Yeah. Wanted to make sure I got the billion in there. About $500 billion a year. And you may not know this, but every doctor's office has a set of people who are, their sole job is to deal with insurance companies. They may never see patients. They're off in the back room. And you know, every insurance company has its own unique set of forms. They're not standardized. So these insurance people, employees, they need to know how to deal with the forms that come from Aetna versus Empire, Blue Cross versus other insurance companies. That's their area of expertise. Save some money. Here's solution number 1. Standardize the damn forms. Excuse me. For the audience, I didn't say that. You'll bleep that out, right? All right, so we spend a lot of money. Do we get what we pay for? Lots of different ways we could look at this. Lots of ways we could evaluate it. Lots of different statistics. I'm not going to go through a bunch of them. I'm going to start with a big one, and that's life expectancy. Life expectancy in the United States is lower than our peer countries. There's an organization called the OECD, the Organization for Economic Cooperation and Development. There are 38 countries in this group. We are number 32 on the life expectancy scale. Life expectancy in the United States also varies by racial group, 4 years less for blacks than whites. And it varies considerably by income. People in the top 1 percentile, top percentile of income distribution, live at least 10 years more on average than people in the bottom of the distribution. Here's a similar graph. Here's all of the developed, our peer countries. You can see life expectancy growing, growing, growing. Again, we're back to 1980, growing, growing. Oh, the United States fell out of the group. And yes, there were some years in the late teens when life expectancy in the US actually fell. The biggest reason for that was issues related to obesity and diabetes and all of the comorbidity issues that go with that. This predates the opioid epidemic. The United States has seen some increases in life expectancy since then, especially since the end of the pandemic, but we're still well below the rest of our peer countries. Do we get what we pay for? Here's a handful of other statistics. We have the highest incidence of chronic disease burden. That means we have the highest percentage of people with very, very serious ailments or multiple ailments, multiple serious ailments. The obesity rate in the US is nearly twice that of the OECD average. US has fewer physicians per capita by almost a whole physician. I think the OECD average is 2.5 per 1,000, and we have like 1.5. We have fewer ICU beds. We saw this during the pandemic. We didn't have enough ICU beds in a lot of places to take all of the people who were really sick in. Avoidable deaths are deaths that, with proper care and reasonable treatment, should be avoided. Some of it's from high blood pressure, obesity, diabetes. Some of it's from things like suicide. And certainly the overdoses in the opioid epidemic. We use more expensive technologies and specialists. That's good, except for 40% of the people in the country use specialists for care they should have gotten from a GP, if there were more GPs. And you know, when you go see a specialist for something you could have gotten from a GP, they're going to bill you specialist rates. Just on and on. We do a good job of preventative measures, more breast cancer screening, more vaccinations by people over 65, especially for things like the flu. But we've seen longer wait times. Anybody seen longer wait times getting into a doctor? Uh-huh. Emergency room use is higher in the US than other developed countries. Emergency room use is more expensive. It indicates that people aren't getting care regularly for sometimes normal things that if they'd gotten care in a reasonable time, they wouldn't have needed to go to an emergency room. Lots of money. Where does all this money come from? This chart shows us some different sources of money over several different time periods. So out-of-pocket spending, how much came from Medicare, Medicaid, private insurance, and you can see the other columns. Back in 1960, these numbers, the dollar numbers, they're not adjusted for inflation, so don't try and do that, and it doesn't matter because mostly we're looking at percentages. A couple of things I'd like to highlight here. The first one is these three numbers. Back in 1960, 48% of expenses for healthcare were paid out of pocket. That means the person had to take some money out of their pocket and hand it over. And I'm going to come back to why I think that's a good thing in some ways. Medicare and Medicaid didn't exist yet, so they didn't spend any money. Compared to now, 10% out of pocket. And Medicare and Medicaid now comprise more than a third of healthcare spending. More than a third of all healthcare spending comes through Medicare and Medicaid. The other thing I'm going to highlight is that last column over there. The heading is Medicare and Medicaid shares of the federal budget. How much of the federal budget goes to Medicare and Medicaid? And now we're up to 30%. 30% of the federal budget goes to Medicare and Medicaid. In case you didn't know this, number one is Social Security. Do you know what number two is? Not anymore. Interest. Interest on the national debt is going to be $950 billion this year. I care about debt too. Bring me back, I'll talk about debt sometime. All right, so more and more spending is done through Medicare and Medicaid. Bigger and bigger and bigger share of the federal budget goes to healthcare spending. And that and interest, they crowd out other things we might like to see our government spend money on. Insurance coverage. In the United States, about 92% of people have insurance. Is that a good number? Yeah. Depends on how good the insurance is. I've got one head shaking.
Should be 100%.
It's not a very good number. Universal insurance exists in almost every other developed country and a lot of less developed countries. More countries have universal coverage than don't in the world. But sometimes we hear it's too complicated, too difficult to figure out. We can't do it. I don't know why we can't. What this means is that 8% of the people are uninsured. With a population of 340 million people, that means about 27 million people in the US don't have insurance. That number is down. Before the Affordable Care Act, it used to be 45 million people in the United States didn't have insurance. So 27 million people don't have insurance. How are you going to get health care if you don't have insurance? That's hard to do in our world. This number surprised me when I first saw it, because I grew up in a household where my dad worked for a big company and we had insurance through the employer of my father. I thought that's the way most people got their insurance. Turns out that's, well, most in the sense of more than half, but it's not a huge proportion. It's a little more than half. Only about 53% of the population gets their health insurance through an employer, and that includes children of employees and spouses of employees and other dependents. I thought it was almost everybody, but it's not. I've got a slide on the Affordable Care Act, and it shows that we've created a new program called an exchange, an insurance exchange, and we got about 6.5% of the people in the country have insurance that's directly through this exchange, this system created by the Affordable Care Act. Oops, I thought there was something else. Yeah, okay, so we'll come back. The Affordable Care Act did several things that helped reduce the number of people who are uninsured. All right, so the title said how we pay for our health care through Medicare and Medicaid. I'm just going to look at the audience and guesstimate that I probably don't have to say a lot about Medicare here. You know, Medicare is insurance for people over age 65 and certain conditions like disability or ALS or end-stage renal disease. Nearly 20% of the population participates in Medicare right now, participates as a recipient, as a beneficiary. Last year, we spent over $1 trillion, and premiums contributed about 180 billion of this. Where'd the other 920 billion come from? Hold that thought for a second, because we got these parts. You know, Part A covers hospitalization expenses, Part B covers physician expenses. Many people don't know that Part C is the same as Medicare Advantage. Medicare Advantage, correct me if I'm wrong, I'm not quite there yet, but getting close, and I need to know these things. I think of Medicare Advantage as insurance that covers the premiums and deductibles that I might have to pay out of pocket for these two and this one. And Part D, created in 2006-5, covers pharmaceutical expenses. So where does all that money for, with that 1.1 trillion, about 34% comes from payroll taxes. FICA on people's paychecks. Most of it is Social Security, but about 1.45% is for Medicare. So it goes into this Medicare trust fund, and that funds Part A. That's where most of the, this is the only thing that the payroll tax goes for. Doesn't fund any other parts. 46% comes from general revenue. What is general revenue? That's our income taxes. The income taxes that everybody pays goes into a general fund, and all of the things the government pays have to come out of that fund, including almost half of Medicare expenses. About 15% from premiums, 5% from other sources like taxes on Social Security benefits that people receive. That's where we get the money for for Medicare. Part A is almost entirely funded by those payroll taxes. Parts B and D, though, are the ones that we should look at, because 75% of the funding for each of those parts comes from general revenues. So it's coming out of the same fund where we're paying interest, trying to pay for schools, trying to pay for infrastructure, trying to pay for military, all those other stuff government does. Part C is also mostly funded by general revenue, but it's a small piece. How about Medicaid, insurance for low-income people? This is a complicated program. It's a program that's administered jointly by the federal government and state governments. It really starts as a federal program, and the federal government says to the states, hey, we want you to administer this program. You've got these local offices to administer both the Medicaid benefits and also some tests to make sure the people receiving those benefits are eligible. The federal government sets minimum requirements, and that's for benefits that people can receive through Medicaid, and also eligibility requirements. And states can choose to cover additional people, additional services, but they have to pay for that mostly. The state does. There's some cost sharing. So what happens is the state pays the money and the feds give them some money back. So there's a percentage of those costs that varies. I think we can just put that up. And it's called FMAP, Federal Medical Assistance Percentage. Varies from a minimum of 50%. So states get at least 50% of their money back, a maximum of 77%. And the exact percentage depends on the income in the state. Mississippi is a relatively low income state, so they get a higher percentage paid back to them by the feds. Higher income states like New York, California, Massachusetts, they only get 50% back. This is an important thing because I'm going to keep talking about this. This is the area of Medicaid that I'm going to talk about when we talk about what happened with the ACA and also what's going to happen with the One Big Beautiful Bill Act. It tweaked Medicaid. Total spending for Medicaid last year, $914 billion. About 2/3 of that came from the federal government, 1/3 from the state governments. We currently have about 71 million recipients, again around, what is that? About 20% of the population. During the peak of the pandemic, April 20, this is a little bit later than the peak, but we had 94 million people enrolled. About half of the enrollees are children. I think it's egregious that children have the largest poverty rate of any demographic group in our country. Children. CHIP stands for Children's Health Insurance Program. And it's a companion program to Medicaid that also covers children, people under age 18. Here's a statistic that I thought was very interesting. Medicaid currently covers 41% of all births. 41%. That doesn't mean that 41% of the births are happening to people who are in poverty, but it's pretty close to that. In our modern climate, I felt compelled to put up some fact versus fiction. Illegal immigrants, undocumented immigrants, are not eligible for Medicare or Medicaid, period. There's a small exception for that. If the state deems that there's a medical emergency, they can offer to provide care for an undocumented immigrant. And that spending comprises less than 0.5% of all of Medicaid spending. It's not a big deal, not a big dollar number. That's it. That's all the maximum amount, 0.5% that goes to undocumented immigrants. So I got several bullets here. What did the Affordable Care Act do? It, first of all, created these insurance exchanges. I said, in my experience, I thought everybody got insurance through their parents' employer or through an employer, but anybody who's ever worked for themselves, run their own business, knows that health insurance is hard to get by yourself. And the idea behind these exchanges was to create a pool, a place where people who can't get insurance elsewhere, but aren't old enough for Medicare or poor enough for Medicaid, where these people can kind of get together and get insurance. Make it cheaper for them. If they're lower income, not necessarily below the poverty level, but lowish income, then their premium could be subsidized by the government. The Affordable Care Act also significantly expanded Medicaid eligibility, up to 138% of the poverty level. In order to make this palatable to the states, the government said, okay, we're going to pay 90%. The FMAP for these people is going to be 90%. The feds pay 90%. Well, there's still 10% for the states to pay. And, a bunch of states got kind of upset about this. The government's going to make us pay more. We don't like that. And they went to the Supreme Court and they got this turned into an optional thing. Not every state had to do this. No state had to do this. But as of now, 41 of the states, including the District of Columbia, have accepted this expansion. And they're both states controlled by Republicans and states controlled by Democrats. This added about 20 million people to Medicaid. So between these two programs is how the number of people who were uninsured dropped from 45 million into the low 20s. It did some other things that got a lot of press, but really weren't as big changes as these things. It required insurance companies to cover children up to age 26 on their parents' policies. Required people to have insurance, and for companies to offer insurance to their employees, to their full-time employees, if they were big enough. Lots of caveats to that, many exemptions allowed. There's penalties associated with not having insurance. Do you know what the penalty is now? 0. So it's really a toothless requirement. Yeah, you got to check a box on your IRS 1040, but if you don't have insurance, nobody's going to penalize you. This one is much bigger than it sounds, preventing insurance companies from excluding pre-existing conditions. This allowed insurance companies to say to somebody who comes to a new job, they're signing up for new insurance, and they say, oh yeah, but I've got this, I broke my leg or my arm last year. It still hurts a little bit. And the insurance company could say, we're not going to treat that. That's pre-existing. You knew that when you came in. It's kind of like your car. The car insurance company won't fix something that was dinged when you started buying the insurance. In a most extreme case, there's a story of a woman who was pregnant, went to a new job. The insurance company said, oh, no, we're not going to cover those expenses. That's a pre-existing condition. Yes, that really happened, and they got a lot of press for that, and the insurance company backed down. But that's the kind of extremes that insurance companies may go to. So this was a significant addition to the law. What does the One Big Beautiful Bill do? It targets those expansion Medicare recipients. Medicaid, sorry. Imposes additional requirements for those Medicaid expansion people. It really targets that population. Tougher work requirements. It could be how many hours they need to work. Many of them are already working. It could be how they need to document their work. One of the changes was that it used to be the case that recipients of Medicaid could get online and say, okay, yep, here's the website, I logged in, I said, yep, I worked, I checked the boxes. Now you have to go to the Medicaid office. Does that sound more onerous? Which is understaffed and open, you got to get there at the times when you're supposed to be working. You have to have a car or accessible public transportation, which isn't great, especially in rural areas.
What is this administrative cost?
The federal government, Congress, said, states, deal with it. And many states are upset about that. They're saying, wait, we got to put new procedures in place, and you haven't given us any time to do it, and you haven't given us any money to do it. And the Congress says, yeah. Additional eligibility verifications. Prior to this, the people had to document that they were eligible once a year. Now they have to do it twice a year. May be difficult for many recipients. It's not just the times, but the amount of paperwork is greater now. The verification of, yes, my income is low, yes, I'm doing the work stuff, or I'm going to school. The amount of verification that you have to do to maintain eligibility is much greater than it used to be. Multiple groups have estimated that approximately 10 million people are likely to move off of Medicaid because of these rules. Congress did not kick people off of Medicaid. It merely tightened the requirements for being on Medicaid. Apologies for my voice. Estimates vary from 7 million to 12 million, but around 10 is what is commonly, the number commonly used. Many rural hospitals have already said, we'll have to close. If we don't have as many people eligible for Medicaid, then we won't have as many patients and we won't have as much income. We're going to have to close. Congress didn't kick anybody off of Medicaid, but they said, we're going to save a lot of money, like $1 trillion over the next 10 years. That's where they get their budget savings to do the rest of the stuff in that law. I was once told I might have 30, 35 minutes. If you guys are getting bored, tell me to stop. I've got 10, 15 minutes more stuff that I can easily do. Some other thoughts. Our third-party payment system is really inefficient. And this is something that most people don't think about. From an economist's viewpoint, most products in the markets, there's buyers that know how much the product is worth to them, and there's sellers that know how much it costs to make the product. And they negotiate and they agree, even if we don't always see this negotiation, there's an agreement on what price they will actually make an exchange for. And these prices are really important signals to our economy. They signal whether enough resources are being put to use making that product. If the prices go up, it says that there's shortages of those products and we need to put more resources into making them. And if the prices go down, it says there's surpluses of those products and we should take resources away from making them. And healthcare, the buyers and the sellers are separated from the price. Price can't do its job. We don't know, not from prices, but that's what we use for everything else. We don't know what the right number of resources to put for healthcare is. High administrative costs, yep. Does anybody know? This is a real question, not a rhetorical one. Does anybody have any idea how much it costs to produce a doctor's visit? Not the $10, $20, $30 copayment. That's not what I'm talking about. I'm talking about for the cost of the doctor, the cost of the office, the cost of the supplies, the cost of the nurses and the training that people got. How much does it cost to make an office visit? I have no idea. I've asked some people in the medical industry. They have no idea. That's a problem. These are random thoughts, not organized together. In practice, we don't have a health care system. We have a health restoration system. We go to the doctor, we seek help when we're sick, when our health is absent from us. Yeah, we go to the doctor regularly, maybe some people for annual physicals or stuff like that. People probably have lots of anecdotes about many different parts of things that I've said. Here's one of mine. I went to my insurance company once and said, would you pay for a nutritionist to work with me so that I don't become diabetic? Because I love sweets. And the insurance company said, no. But if you become diabetic, we will pay for a nutritionist. Yeah.
How much does the cost of pharmaceuticals, which also isn't under our control, contribute to all of this? Because facts being manipulated hugely.
Yep. I've got a couple things on pharmaceuticals a bit later, but you're right. Generally, there isn't any one area that contributes a lot more than any others. All of the parts have these problems.
Exactly. Right. And it's getting worse with the private equity.
Yep. I don't know about you, I had a need to go to a doctor 2 or 3 years ago, and I thought, oh, well, I didn't like what the doctor said. Let me get a second opinion. So I looked at the list of doctors, and they were all in the same practice for that specialty. It's like, wait a minute, this isn't right. Okay, so the title of this section is Increasing Concentration in Specific Markets, in Specific Industries. And the first one is about the pharmaceutical industry. The pharmaceutical industry, well, we know that prices are higher in the United States than they are in other countries. We're told that in the United States, prices are higher because most of the research and development for not just pharmaceuticals, but all new medical procedures and techniques and equipment, most of that happens in the United States, and the companies need to recoup their R&D costs. That's what we're told. It's plausible, but why do they have to recoup it all from us? I don't know. I love this one. Medicare Part D is prohibited from negotiating prices with pharmaceutical companies. Every other insurance company, and Medicare is the biggest insurance company in the country. Every other insurance company negotiates with pharmaceutical companies, and they tell them, okay, we're going to take this drug and this drug and this drug that you make, and we promise if you give us discounts on those drugs, we won't take drugs from your competitor. So they get discounts on these drugs. The VA negotiates. The VA gets big discounts. Medicare Part D the Congress wrote in the law, they're not allowed to negotiate with pharmaceutical producers.
I thought that was changed under the Biden administration. That didn't happen?
So what happened is they picked 10 drugs that have a lot of use, and they said, we're going to have a pilot program. And I think it starts next year. It might have started this year, but I think it starts next year. We're going to allow Medicare to negotiate prices of those drugs with pharmaceutical companies. 10. If it goes well, for who? Won't go well for the for the pharmaceutical company. But if it goes well, we might expand it to more. Yeah, so they're trying to head that direction, but a lot of resistance from a very powerful pharmaceutical lobby. Between 1995 and 2015, 60 big pharmaceutical companies merged into 10. Less competition, more market power for those 10 companies. Similar problems in the hospital industry. Hospitals are merging. And venture capital has a lot to do with this. Mergers mean less competition between hospitals and medical groups. And I didn't put it up here, but I forget there's a word for it, the profit margin that hospitals charge in some cases is 300% and 400%. And the less competition there is, the more they've charged. Between July of 2016, January 2018, hospitals acquired 8,000 more medical practices, 14,000 more physicians left independent. That's just 18 months. It was probably cherry picking a high time, but this is something that's been going on and it continues to go on. If there are fewer doctors' practices, then there's fewer choices about where do you go. I mean, yes, you can go to this doctor or this doctor, but they both work for the same company, so they're both going to have the same pricing practices. And what we've seen for hospitals is one of the things when companies merge is they try and reduce the amount of duplicated tasks. So they close some hospitals. And this by itself has left some rural areas, especially rural, without hospital care, where you've got to drive an hour now instead of half an hour. The insurance industry has also seen problems. Over the 20-year span here, health insurance premiums rose at an annual rate of 6.5%, but inflation was only 2.2%. One of the problems we have is that in the United States, every state has its own insurance regulation board. Every state has its own insurance rules. And so there is no nationwide Aetna or Blue Cross. There's Blue Cross New York. There's Blue Cross Massachusetts. There's Blue Cross Connecticut. There's Blue Cross New Jersey. They're all separate. And so within any particular state, if one company decides it's really not profitable for us to be there anymore, Companies have withdrawn insurance coverage from states. You might have heard property insurance. This is happening for property insurance in California and Florida. California because of wildfires, Florida because of flooding and potential for storm damage. Property insurance rates are ridiculously high, and many people are told they can't get insurance. Of the 50 states in the District of Columbia, 21 of them had only 1 or 2 insurance companies operating in them. Ouch. I like having choices. Choices mean competition. Competition means prices go down. 14 had 3 or 4, and 16 had 5 or more. Not a lot of choices. All right, some miscellaneous things. Here's a big one. Is healthcare a right or a privilege? This is not rhetorical, but I don't expect an answer. I ask my students this.
What did they say?
I've found that it's helpful to provide examples of rights and examples of privileges to help them think about the difference between the two. And an example of a privilege is driving. Privilege? Driving's a privilege. You have to get a license. You have to get permission, not just from the state, but if you get old enough, you might need permission from your kids or your spouse or, stuff like that. Rights. Well, we say we have a right to free speech. Life, liberty, the pursuit of happiness. What do those things mean? What does it really mean in practice when we say those are rights? And then come back to, is healthcare a right? The way we treat it, it's like a privilege. If you want to say it's a right, that's fine. I'm not going to disagree with either position here, but it should influence how we create policies. If you think it's a right, then we should have more government intervention, subsidies for insurance and care. We do have that. Unfettered markets aren't going to achieve that. Another word that sometimes gets in here is it's a moral good. Yeah. You know what? I'm going to put those up there. And I've already talked for more than 10 more minutes. So here's some closing thoughts. The growth of healthcare spending and increasing dependence on government budgets, I should have put are, because I'm treating those as 2 separate things. They're both unsustainable. We already spend 18% of our output on healthcare. Can you imagine spending 25% of everything we do in the US on healthcare? I'm not sure what that looks like, but it means the word economists use is crowding out. It's going to push aside other things that we might want to produce. Same thing in the government budget. The more we spend on healthcare, the more we spend on interest, the more it pushes aside other things that we might like to do. People don't like this one when I say it. I'm going to tell you something else. Healthcare is already being rationed in the United States. Who does that rationing right now? Who does the rationing? Do you know? Insurance companies do the rationing. They decide who gets care, what kind of care, and who doesn't. There's arguments that can be made that it would be better if that was in the public sphere, if we could see and have input into those discussions. I shared this once with a conservative friend some years ago, and he said, I don't want the government to do it. I'd rather have the insurance companies doing it. And I asked him why, and he had a reason. He said, because if I want to argue with them, I'm more confident that I could beat the insurance company than I could beat the federal government. Then I could persuade them to see things my way. He makes a good point. Change the focus from maximizing profits to maximizing health. Many other countries do that. Economists recommend cost-effectiveness studies. Suppose that pharmaceutical companies make a new pill that treats something so much better than the old pill, but costs 10 times as much. Wouldn't you like to know if it's worth it? If it's worth that extra 10 times? Suppose you don't get to pay just the co-pay. You got to pay the 10 times more. You'd like to know. But the medical profession won't let us do cost effectiveness studies because they don't want doctors in the position of having to inform patients of, you could have this pill at this price or this pill at this price. And here's the difference between them. They don't want doctors having to do that kind of stuff. Doctors want just to be able to say, here's the latest treatment, we're going to give it to you. Somebody else will pay for it. Lack of electronic health records, this would be an easy thing, and some of you already participate in some of this, I bet. We're starting to see electronic records online, but imagine if we had a centralized database where everybody's health records were kept. The benefit for that, the reason we talk about things like that is sometimes people are traveling or they move to a new area and something happens to them, they have to go to the doctor. And the doctor doesn't know their history. It doesn't know they have an allergy to something. It doesn't know they've been treated with something and it didn't work. It doesn't know their history and can't look it up. And sometimes mistakes are made and doctors give the wrong treatment, the wrong piece of advice or something that harms the patient. So we would reduce errors, we would reduce problems like that if we just had common medical electronic records. People don't like that because there's privacy issues. Yeah, I get that. Yeah. All right, the last thing, some helpful websites if you want to look at this more. By far, if you're interested in learning more about healthcare, go to this website, the Kaiser Family Foundation. They write in plain English. They have dozens of reports on all different aspects of healthcare. They try to be relatively unbiased. They are left-leaning. To government organizations, for now at least, they're unbiased. The Centers for Medicare and Medicaid Services and the Congressional Budget Office. I have a friend who works for the CBO. He tells me they work really hard to be unbiased. They write reports on everything the government does and how much does it cost and what's going to happen, including healthcare stuff. All right, I kept it under an hour. Thank you, I'm done. Questions, comments? I don't know when you throw people out or if you do that, but I'm around for a while now. Go ahead.
You spoke very well, I think, about physicians' organizations and hospitals. Can you make any comments about rehab and nursing homes, particularly how the partitioning between Medicare and Medicaid, which to me is very confusing?
I don't know a lot about that. I do know that because of attempting to control costs, Medicaid reimbursement rates have been so low that many providers no longer will take Medicaid. And that's obviously something that rehab and nursing home places are also going to think about. And what that means then is that the levels of care in those places are probably not going to be as high because they're not getting paid as much for the care they're providing. I don't know much more than that, but yeah.
So it seems like the for-profit motive, which distinguishes us, is the biggest problem. And as I said earlier, it's getting worse with private equity. It seems like an unsolvable problem. I mean, the only answer is more regulation, which there's very little appetite for.
True.
Rid of it, socializing medicine, it almost doesn't seem like a possibility.
So let me separate two terms: socialized medicine and a single payer. Socialized medicine means that hospitals and doctors are government employees. The UK has that kind of system. Canada has a system where doctors and hospitals are still private entities, but the government pays for all the services and negotiates them. So that would be a step in that direction. Now, you can still have profit motives, and we do like, as an economist, I can't say no to profit motives. Well, then you need some regulation. What are they doing? Well, how are they doing it? Are they still creating the benefits that profits get?
What about states like New York where you have non-profit hospitals in New York have to be nonprofit, but they're competing in this for-profit world.
The for-profit stuff mostly comes up for pharmaceutical companies and I would say doctors and other producers of medical services and equipment. I don't see hospitals as by themselves as having a big problem with that. Yeah.
I've been told that some of the ACA exchange programs have such a high deductible that you wind up with no insurance. Can you speak to that?
There are 4 levels in the ACA exchange programs. They call them the bronze, silver, gold, and platinum. And they have different levels of deductibles and different level of premiums. And they also have then different levels of government-provided subsidy depending on your income. And you're right, with the bronze, it's considered catastrophic insurance. It's if something really bad, you're in a car accident and you're having $300,000 worth of care, it'll pay for most of that. But you need a shot, it's not going to pay for that. Yeah, so it's available, and I think that's a good thing for people to have available, because that's all they want. You know, when I was 20, I was indestructible and invulnerable, and that's the way 20-year-olds think. Go ahead.
If we had a single payer system and universal coverage, it seems to me basically we get rid of insurance companies, and that gives you a hell of a lot of money to play with.
Yeah.
But where are they gonna go? Like, they're not going anywhere.
Well, if we got rid of them, they would be gone.
Well, I don't know. We're getting rid of government employees. They have to go somewhere. So as an economist, I say, well, these are resources. They go out in the economy. They have skills. So they'll probably go to finance. They'll probably go to Wall Street. Actuaries. Yeah.
Yeah, I could do that.
So they're shareholders.
Socialism is considered a dirty word in America, and the graph started in 1980 when the arch enemy of socialism, Ronald Reagan, came along. But America was the foundation of socialism. I'm a retired teacher, and the Northwest Ordinance in 1787 required public education paid for by the taxpayers. I believe we're the first country in the world to become socialist.
I believe that's true.
Education.
Yep.
And we allow ourselves to be brainwashed by people who think that capitalism is everything and socialism is nothing.
Right. And we also have a lot of people believing nowadays that we can reduce government and they won't suffer.
Well, Texas is proving me wrong.
Ted Cruz would say everything worked fine. That's what he said. Go ahead. Yes.
You're 53% of people that get healthcare through employers. I would guess that number was much. There wasn't a time frame of that or what happened over time. I would assume like in the 60s it was way higher.
Yes. Yes.
Right before the Affordable Care, it was way lower, and then
Yep.
it came back up with the Affordable Care Act. You have some idea?
Actually, I know that it used to be up in the upper 60s. I want to say like 20, 25 years ago was when it was that. I don't think there was much change because of the Affordable Care Act. Because even though there's a requirement that businesses of a certain size with a certain number of employees working full-time, defined as 30 hours or more a week, are supposed to offer insurance to their employees, what they did is most companies cut back the hours of their workers. So they didn't have to offer them insurance. Or offered insurance doesn't mean paid for it on behalf of the employee. So I don't think it changed much with the ACA. Yeah.
So I know you're not a sociologist, but given how awful it is, why aren't people more upset? Why aren't they doing more, right? We saw with the CEO shooting, right? So this like groundswell of anger. And then it's kind of like dissipated. Like, why aren't people in the streets over this stuff?
What motivates people? Money. Money is the biggest thing. How it hits them. Wait. Do you know what they did with the timing of the One Big Beautiful Bill?
Yeah, put it on after the midterms.
After the midterms is when the Medicaid restrictions go in place. After the next year's elections. So it's not going to be for at least 2 years and probably 3 years before people start feeling pinches from this.
Everybody's mad now. Like, people are mad.
Yeah, but Okay, I was going to say this about the additional bureaucracy and red tape. My guess is people in this room are above average intelligence. And I bet everybody in here has a story of dealing with government red tape. Imagine a low-income person dealing with more government red tape. Who is sick, or working 2 jobs with 2 kids, or 3, or whatever their situation is. It's really difficult. You're trying to get by. Yeah.
Another question.
Go ahead. You started.
One of the most shocking statistics you showed was the 1% and the
Top 1% and bottom 1%.
bottom 1% and the difference in life expectancy.
Yeah.
Has that widened with time, and is it widening with time?
I'm sure it has widened with time. But I don't have data. I don't have the statistics. Since you mentioned it in that context, I'm going to tell you that was not the most shocking statistic I came across. The most shocking statistic that I came across is about maternal mortality. Listen up. Not infant mortality. This is mothers dying in childbirth. Black women die at 4 times the rate of white women in childbirth. 4 times more likely to die in childbirth.
Yeah, prenatal care.
Yes, some of it's care during the childbirth. That's not the same either. You had a question?
It's even upper income. I mean, regardless of income.
I was just going to observe that corporate red tape is no better than government red tape.
Right.
And the person who thinks he could, that you mentioned, who thinks he can talk to an insurance company and get a better deal than with the government, what he's missing is that with the government, you can vote. You can change the people in charge.
And you can't do that with
No
companies.
defense against corporations.
Yeah.
But if you have
Yeah.
enough sway, you can, get your insurance broker or your HR department or, somebody to advocate.
Where do you
I'm
get
a
such
psychologist and
sway?
I spend endless hours on the
Your
phone
senior-
getting care for patients.
Going through the approval process. Yeah. Anybody else? People who haven't spoken, additional questions? Yeah.
Did I read in one of your slides that in 1980 the government wasn't paying for Medicare?
1960.
60, so who was paying for it?
It didn't exist. It was created in 1965.
Oh, okay.
I just put that there to provide a comparison without Medicare and Medicaid. Here's what things look like.
And the VA negotiating for the drugs, was that new?
New. No, that's not new.
The entire.
That's been there. Yeah. And I didn't have this up here. I think it was the Congressional Budget Office estimated that if Medicare Part D could negotiate like the VA, they would save $500 billion over 10 years. Easily.
You talked about how prices are high, partly because of all the R&D happening. And we're defunding NIH and NSF. And I assume that just means it's going to get more expensive, or the research is going to have to happen in other countries.
No, it means less research will happen.
Right, well, that's for sure. That's for sure.
And we can't expect, sounds like rain. Not just misting. Less research. No, before this, I want to say like 60 or 70% worldwide, 60 to 70% of all medical research was done in the US.
Well, I was told recently that all drugs are made outside
For
the US. 100%.
Made?
Outside the US.
Produced is different than research.
No, the research I know, but the production is.
Oh, that I believe. Other countries have a comparative advantage in making things that we've already designed.
Are tariffs pretty good on
Exactly.
drugs?
That's why the tariffs are so important for pharma companies.
Yeah. Yeah, they're going to attach tariffs to pharmaceuticals.
Just a point of clarification. I pay an insurance company for my Part D. So those drugs are negotiated by the insurance company. So I would pay a different amount for a different drug going with one insurance company or another. In fact, in a particular insurance company, if I go to one drugstore, I pay more than I do at another drugstore. So your comment about Medicare, this might be only the hospital usage of drugs. I'm not sure.
So I wonder, not knowing enough about exactly how the separate insurance policies work, but my suspicion is that Medicare is kind of saying, okay, to insurance companies, you provide this insurance, we don't want to deal with it.
That's what I think.
But as a body, Medicare has the ability, the gravitas to negotiate, and it's just saying, no, we're not going to do it. They're saying, yes, the whatever the insurance company is that you're going with, they can negotiate. They don't have as much power as we do. We could. But yeah, I think it's because each individual insurance company is negotiating with pharmaceutical companies that you get the discounts.
Part D is set up.
Yeah, but why isn't it set up like the VA?
Well, that's for our legislatures to figure out.
Yeah.
I was just going to, it's Congress that prevents the Medicare itself.
Correct.
And it's a particular part of Congress, too.
Yep.
And everyone should know that.
Yep.
What do you mean?
The Congress was controlled by the Republicans when George Bush was president and created Medicare Part D. Mm-hmm. And they specifically wrote in that Medicare may not negotiate.
Yeah. However, there were also many Democratic senators who received donations from the pharmaceutical lobbies.
And that's the larger problem, money in politics.
Yep. Yep. All right. Adjourn to the bar for further discussion. Thank you all. I appreciate your time tonight.